Hi, Dr. Douglas.
Hi, Abby.
Welcome. So happy to have you here.
I'm very happy to be here. Thank you for having me.
Yeah, so Extend Fertility. Let's get right into it. Did you always want to be a reproductive endocrinologist?
So, I always wanted to be a doctor. And then shortly after that, I wanted to be a scientist. I came at reproductive endocrinology and infertility when I was doing my PhD, and I was a teaching assistant for this course called Biology of Reproduction. And that's where I really, sort of stumbled into it, right, to understand all of the amazing things, early in the 90s that were developing in the space of reproductive endocrinology and infertility. And so IVF, testing embryos, all of that was starting.
Had you known about any of that previously? Did you know anyone who had been through it?
No, I didn't. I was in my early 20s. I knew I loved women's health. I had been a volunteer as a high schooler, as a college student, teaching sex ed to middle schoolers. So I knew I was interested in women's health and taking care of women. And then when the science piece really, kind of piqued my interest, that's how it all kind of came together.
Amazing. So at that point, were you like, this is for sure my path? Or did you just sort of start exploring what the options are?
So wasn't sure it was my path. I knew it was a science interest. And, part of our training then in medical school requires testing out all the different sort of subspecialties. And so I did general surgery and I knew I liked to operate. I did pediatrics and I knew I did not want to take care of children, more so
So
the
funny.
parents of the
I get
children.
that exact answer from most reproductive endocrinologists. I knew I wanted to do surgery and I knew I did not want to go into pediatrics. It's very trendy.
It was very clear. It's very
Yes.
clear. And so I then did my OBGYN rotation and loved it. Really loved all aspects of care for women, and knew that, sort of the questions that weren't answered in one aspect of our care for women were the questions around fertility and infertility.
Amazing. So once you committed to this track, what were your next steps? Where did you think, what did you set your goal to be once you committed to this track?
So I had committed to life as a physician scientist since I did both my PhD and my MD. And my commitment was to, further our field and take care of women the best I possibly could. And so I've, sort of worn two hats all the while. The balance has shifted, sometimes more clinical, more research, but I've spent a good portion of my career looking at both the uterus, the endometrium, trying to understand what makes up the endometrium and what makes it a great place for an embryo to implant and a successful pregnancy. I've spent a portion of my career looking at ovarian reserve testing with anti-Müllerian hormone, the AMH marker, like how we use that, how that can help us counsel women. And then I've spent the other portion surgically a bit, but more so seeing women through their, fertility and infertility journeys as they come for consultation and treatment.
Okay, great. Let's break this down. Let's start with the endometrium. For people listening, that is the lining of the uterus. Can you tell us some of what your research has entailed?
Yeah, so the research started off as being very, very basic, actually using mouse models. But fast forward about 10 years, now looking at samples from endometrium from women who have infertility and are undergoing IVF compared to women who have had successful pregnancies. What we found is that the immune cells, the cells that we think about, oh, fighting infection, and can get ramped up with inflammation, those cells, as well as the blood vessels, are really important in creating this endometrium that is ready to talk to a healthy embryo and start a pregnancy.
Amazing. So I'm going to break this down a little bit for some of my listeners because we talk about the role of your immune system in fertility. That's what we're talking about here. So we talk about sometimes you put an embryo in, your body thinks it's a foreign object. And so your immune system is like, foreign object, we have to reject it. And they reject it. I am somebody that did an autoimmune protocol with no
Mm.
diagnosed autoimmune issue, and it ultimately was part of my successful transfer. And so I'm very fascinated by this topic. And there's also, I feel like, a lot of skepticism about this topic. Some doctors think it's complete BS, there's nothing to it. So how, and I'm like, but it works for people. It makes a difference. I also Lovenox, much to the
Yep.
blood vessel piece that you were talking about, which is a blood thinner that makes the blood move a lot faster to support, not faster, it makes it thinner so that it
Thinner.
can
Yep.
move. Yeah.
Exactly. You're
So that
right.
it can support the uterine lining and all the things that are needed for the embryo. Some people think that's also BS. So I love that this is your research. How can we make it a more universal piece of the process for women undergoing infertility treatment?
Yeah. So great questions. And thank you so much for sharing your experience. And you're absolutely right. For some women, immune protocols, taking Lovenox, taking baby aspirin is really important and helpful for getting pregnant, right? And also having a successful pregnancy, right? Coming to term, avoiding preeclampsia, avoiding pregnancy loss. So I think getting it to a place where everyone is kind of tested to understand if we need that, we're a little bit far from there. I think what my research is, and the most recent research is, kind of telling us is that there's a lot that we still don't understand. And we don't know how to non-invasively test for these things, right? Like, each pregnancy is a little different, but it's still our uterus and our endometrium, right? So I think we have a ways to go. I think, bless you, I think
Thank you.
knowing the factors that are important is the first step, right? My dream would be to have kind of an endometrium or a uterine factor test similar to our ovarian reserve test, right? Where we could identify red flags,
Mm.
right? Just to be able to say, this is far from where I expect you to be in terms of what's the quote unquote norm. And we could prevent some of these, implantation failures or early pregnancy losses that we have. But
And
but
do
we're
you
not there
know
yet.
what is it? I suppose if you knew this, we would be there, but what is it that you would be testing for?
So yeah, so I think we would be testing for the genes and proteins, right, in the microenvironment, right?
Mm.
We may be testing for the particular fluids that are secreted, or that are, released at the time of implantation, testing for maybe even the structure. When we look at embryos, we can test whether or not they're normal or not based on how they look. And also we can test for chromosomes, right? To say this is a normal male or normal female embryo. We can't do that with the uterus. We don't know how to test. What we do is we do an ultrasound, right? And we say, ooh, the lining is thick enough. The lining has this lovely three-stripe pattern. But that's very crude, right? Like
Mhm.
that doesn't give us as much information as we know we need. And so the field has to evolve.
Mm. Okay. Now let me just ask you one other thing. If you find this testing and we make it work, do you have thoughts on the way we treat it? I know for me personally, right, like the autoimmune protocol was Lovenox, IVIG, steroid, Claritin, Pepsid. There's different versions of this. What do you think would be the most effective way to treat this?
I think it would depend on what we find. I think we would the goal would be to identify someone who is at risk and does need a, sort of an immune modulation protocol, right? And then we use the protocols we have. The first is identifying women who could benefit from that protocol before there's a loss, right? Before there is the adverse outcome. I think that's the key.
Mm. Yeah. Do people come to you specifically because because the autoimmune piece is your passion?
No, no.
Okay.
I mean,
No.
it's my passion. It's from a research standpoint, it's my passion to understand.
Hmm.
I am not an expert in the therapy. I
Hmm.
oftentimes will refer people to, some of the experts in the field who've been spending a lot of time, you know, um,
In the immunology
in the
field
immunology
specifically.
field. Exactly,
Got it.
exactly.
Got it. Okay, let's move to your next phase of research, AMH. As
Yep.
you mentioned, anti-Müllerian hormone, which is what we test for your egg reserve. Often put a lot of people put a lot of weight on that number. Can you explain why and why we might not need to?
Yeah, so AMH is, as we said, it's a marker of our egg reserve. It's a marker of our egg quantity, a snapshot in time. Doesn't tell us about quality, right? That is related to our chronological age. So AMH is made by a type of follicle in our ovary. AMH really gives us as it's the single best blood marker of egg reserve, right? We can test it when we're on birth control pills. We can test it, at any point in the cycle. However, we know there is variation, right? So the other thing is we couple AMH, right, with an ultrasound to make sure that it makes sense. So the antral follicle count is actually seeing those follicles that make the AMH. And so those have to be in sync. So sometimes when people don't put a lot of weight on AMH, it may be because, our ovaries have so many more follicles than our AMH level may suggest. We put a lot of weight on it because it tells us kind of where we are. I find it to be most important for helping us understand outcomes with respect to egg freezing and IVF, like the expected number of eggs one could expect to get, but also sort of for tracking over time. I think one of the things is if we're thinking about, our quantity of our eggs, we don't know how any particular person's egg supply will decline over time.
Mhm.
And so, if we started testing our AMH at age 25, we could see how it declines, and that may be something that helps guide us towards doing a process like egg freezing, if we're not quite yet ready to start family building.
Literally,
So
one of my life missions is to get a standardized test of AMH at 25. I mean, there is just no reason why we don't do it.
there's no reason why.
Yeah.
I mean, I think we're getting there.
Yeah.
I think that would be, part of it is there has to be the education with
Yeah.
it. We don't want to cause undue anxiety. But I do, believe, and even in 2016, when I first started studying AMH, we did a study where we looked at women, we tested AMH, and when women found that their AMH was low, they started, thinking about their life goals, their family building goals a little bit differently.
I mean, knowledge is power. That's the whole point, right? It is. You don't want to scare off people who might not have anything to worry about, but if you have that information, you can make informed decisions. Okay, so what piece of the research are you still doing AMH researching?
Yeah, and we are actually. So just this past year, we looked at 8 years of data from Extend Fertility and sort of two pieces. One was to look at AMH across ages. So it's been over a decade since anyone has published or reported on what do we expect for of an AMH value for a woman who's 34, a woman who's 37. And so we looked at basically 5,900 individuals who had come to us for AMH testing, and some of those, about half, had gone through with actual planned egg freezing or planned oocyte cryopreservation. And so we pretty much created a normogram where, you could say, okay, I'm 34. What do I expect my AMH to be? What's the median value? What's the fifth percentile? What's the 95th percentile? So that was one part of the research, and then we paired that with the egg yield. So we had over 3,000 women who did egg freezing, and so now we sort of have a tool that we can counsel women to say, if you are 34 years of age and your AMH is 2.3, this is what I can expect in terms of how many eggs we have frozen in one cycle.
And the number that you freeze in a cycle will not dictate necessarily how many live births will happen. And so, one of the things that I see in terms of my coaching people who are egg freezing is doctors are not always perfectly clear on how many cycles a person should do. And it can be really hard because people get six and they're like, oh my God, I have six. I'm going to have six children, right? We don't, again, back to the education piece of it. How do you counsel people on that? Do you have a standard number you want to see based on age and AMH and all those things? How do you do that?
So my approach to every consultation is really the education piece as to how age impacts our egg quality and the quality of the embryos that we make, and then how our AMH level will help us understand how many eggs in one cycle. And then, sort of almost equally important is understanding what is that individual's goals for family building. So we put all those pieces together, and that is how we'll come up with an expectation for how many eggs we think we'll get in a cycle. And then the younger you are, we know that when we're younger, our egg quality is higher. So, having 10 eggs frozen when you're 25 is not the same as having 10 eggs frozen when you're 35.
Mm.
And so there are no exact numbers, but it's a range. On average, we want to have somewhere between 15 to 20 eggs frozen for, the highest possible chances. I can never say 100%, but if I could get there, when you're less than 34, right,
Hmm.
of one baby being delivered.
Amazing. Okay, can we talk about your personal story?
Sure, sure. Yeah.
And I also want to talk about, you said before, the balance between your research, but also what about the balance in your life? You're a scientist and a doctor with a PhD and an MD, and you're a mother. So let's
Yes.
get into how does it all work out?
Yeah, so I'm very lucky, very, very lucky in it working out from the motherhood piece. So, my training had me enter residency when I was 30,
Mm,
and I got married when I was 37. And so that's when I obviously I knew enough. And the best piece of advice that I got before I got married, one of my mentors said, "Don't test your AMH because it would only potentially make you worried if the number was low." And
mm,
at that time, egg freezing was not so popular. I couldn't afford egg freezing, just finishing my training either. So fast forward, we got married, conceived relatively easily, and was very excited at 6 weeks for a pregnancy in December or so. And then fast forward to about 18 weeks, and I had a pregnancy loss.
mm,
It was a loss that I actually diagnosed myself because as a reproductive endocrinologist, I'm around ultrasounds all the time, and I felt really bad the whole pregnancy,
mhm.
just morning sickness all the way through. But yeah, so that was unexpected to say the least.
Yeah, we don't often hear the emotional piece of what doctors themselves experience. When you diagnosed it, you were having symptoms that were questionable. When you like, did you do an ultrasound? Like, what did
I
you
did,
do?
yeah, so
Mm,
I basically was, in the office and decided that I was just gonna, check on the fetal heart. I was 18 weeks. I didn't feel particularly worse that day than any other day. I just felt bad. This notion of, oh, everyone feels great by the time they enter the second trimester just was not happening.
mhm.
And so I did, and I was like, oh, looks like there's no heartbeat. And so
But
I
it was
had one.
unexpected to you. This
Unexpected,
was a
completely
shock.
unexpected. It was a
Yeah.
shock. It was a complete shock. And then I had one of my colleagues come and confirm, and I don't think it sunk in for probably a good, I don't know, maybe close to a day. But they took me home, and I ended up having to have a D&E,
Mm,
because obviously I wasn't laboring. It was unexpected. And in retrospect, if we can think of, could we have predicted it? Maybe. My first ultrasound, it looked as though I may have had some scar tissue in my uterus. And prior to conceiving, probably 2 or 3 years prior, I'd had a hysteroscopic myomectomy.
mhm,
So I had fibroids that were causing heavy bleeding, one in particular that was in the lining of my uterus. So that had been removed, through the vaginal route hysteroscopically, and my cycles went back to being normal. So I didn't think anything of it. But on reflection, I sort of go back and say, oh, that very first ultrasound at 6 weeks where everything looked great. There was a mention of maybe there was, some whitish echogenic structure that maybe shouldn't have been there. Um, but so yeah, so that was
Traumatic.
devastating, right?
Yeah,
Really devastating.
sure.
And,
Were you able
you
to
know,
test any of that tissue?
I did. It was completely normal.
So,
So,
so most likely something having to do with the uterus. Oof, I'm sorry, girl. I'm
right.
sorry.
So
Okay.
yeah,
So how did you do the work for yourself to move on? And were you still working I mean, you're working in the
still
field.
was working. Was working in the field. I will say that I'm a person who, because I love my work and what I do, I'm, able to focus for the time that I'm at work, do the work, and then, sort of came home to think about, well, now what can I do? I'm a runner,
Mm.
so that's my sort of happy place. Also yoga, I started doing at that time. And so those were the things to really help me heal, mentally and emotionally, and think about sort of next steps and how to move forward. My
How did your partner handle it? And how I find a lot the pattern that you handle it very differently. Did you find that it was handled very differently by each of you?
I think so. I think, well, so my partner is also a physician. He's an ICU physician. And so
Mm,
I think we both handled it from a let us get the information we need. We know that this happens, right? So miscarriages happen when they're that late in the pregnancy. It is typically unexpected. So we both took it from the lens of let's do the investigation to help us process to see, how we can move beyond this and also put ourselves in the best position for a successful outcome the next time.
okay. And
Yeah.
how long did you give yourself before you were ready to start trying again?
So that was Valentine's Day of 2008.
Mm,
And my son was born April 2009.
okay.
So not long, again, we went to look at my uterine cavity after the D&E just to make
Mm,
sure, right, that there was no residual scar tissue, which I think is hugely important. Once we've had a procedure in our uterus, we definitely need to go back and check, right? And then pretty easy to conceive again. I think that that time in between was really hard.
hmm.
I was seeing women who were having difficulty conceiving. I was seeing women walking down the street who were pregnant, and that was just so triggering,
Yeah, you
right?
see them everywhere when you don't want
Everywhere,
to,
right?
right? Yeah.
Everywhere. And I was like, geez, why is everybody pregnant?
Yep.
Like you didn't notice
Yeah.
before. And so it was really a hard time. But I felt I was comforted by the fact that I knew so much and also knew that if I wasn't successful in a short amount of time, I knew what to do,
Right.
that there was therapy that worked and that we could access. And everyone was so supportive, right? My colleagues and my friends.
Good.
And so easy conception. And, I then 26 weeks or so. And I was having extra monitoring because
Mhm.
we did testing, a normal fetus, nothing that we could detect was wrong, but I was having extra monitoring. And at about 26 weeks or so, I remember this evening I came home and I was like, I feel like I felt this baby kick while I was in a lecture at 1 o'clock. But then I woke up the following morning and thought, I don't think I'd felt this kid kick. So that was my running morning. And I said, no, you know what? I'm actually not going to get on the treadmill this morning. I'm going to just go into labor and delivery and just check it out and make sure everything's okay. And it wasn't okay. That he basically only got 2 points in a full biophysical profile out of 10. And the 2 points were for my fluid.
Mm,
So wasn't breathing, wasn't moving.
mm.
And I basically needed to be delivered. And so that, of
Oof.
course, was, I, and of,
More
and of course,
trauma.
more trauma. And of course, I
Yeah.
hadn't told anyone I was going to the,
Right. Like I'm just gonna
to
get
triage.
checked.
I'm just going to get
Right.
checked, and then I'm just going to go on to my lab,
Right.
and all will be well.
Ugh.
So yeah, so I remember calling, calling my husband, calling my mother, and they were like, "Oh, okay." And I'd found out that I had some minor factor deficiency that made us think that I should not have an epidural. So basically, looking at general anesthesia, um, and the NICU came. I don't think I heard anything other than, it's 26 weeks and 2 days, and he was being delivered.
Mm,
But fast forward, he's absolutely perfect 15-year-old. But it was
amazing.
a lot. It was,
Sure.
ET, OT, 10 weeks in the NICU. But all of this, I have to say, has really given me such an appreciation for um, these adverse outcomes, right? That, when
Yes.
and you can't describe it. You really can't describe it. And to have such empathy for my patients who are experiencing any kind of loss or just unable to conceive.
Do you share it? Do you share it with them?
I readily share when anyone asks me for two euploid embryos for twins, that they are desiring twins. And so that's when I say, listen,
Yeah.
I've had one deliver early, and that was again completely, who knows? I think I just make a bad placenta. I mean, at the end
Mhm.
of the day, I think my uterine lining just somehow, I don't make a good placenta that's supporting a
But
pregnancy.
but you did go on to have more children.
I did. I did. I had yes, my middle guy was term, but my last was 34 weeks, and I had preeclampsia.
Mm,
Um, and she was a bit growth restricted. Still 34 weeks, came home with me.
sure.
So I do think that, my uterus is probably not the best place, but it did okay. It did right by me in the end.
Were you incredibly anxious during your pregnancies after
All the
you had
time.
the all the
All the
time?
time.
Hmm.
Yeah, every step. Like I
Hmm.
said, in addition to not feeling well,
Yeah,
I was constantly, in the back of my mind, sort of waiting for the other shoe to drop.
sure.
Um,
Yeah, I was the same way for 9 full months,
yep.
37 weeks one day.
Yeah.
Um, what's your favorite part of your job?
My,
Besides the results, obviously, when we
well,
get the baby photos is the best part of the
yes,
job.
yes, yes.
But up
I think
until there.
I think the best part of my job is to truly every conversation, at the end of the conversation, when I get the feedback that this person, this couple feels like they've learned a lot, and I took the time to explain things they didn't understand or had never thought about. And the goal is not to push anyone to make any decision any faster, but really to provide the information. And so that really is the best part, to
I
leave
love
every
that.
consultation feeling like I've touched someone, I've, provided a space for them to share, I've provided information, they feel empowered. Um, but yes, the pregnancies, of course.
Yeah, sure.
Um,
And I think we can all agree more women are coming in for egg freezing, which feels very like, great, we're doing something right. We're educating, we're explaining why this can be done. Do you think the same for IVF for couples?
I do think so.
Mhm.
I am seeing much more couples coming in earlier. I think in their relationship of trying, I am seeing couples coming in where, the partner has done a semen analysis already,
What a dream.
which is
Wow.
great,
Yeah.
right? So I do think that overall we are shifting in our understanding of the fact that age really drives our success.
That feels
And
so good to hear because I think we talk so much about how sex education's not enough and people don't know, right? And it does feel like we've made a little progress. Even as you're saying this, I'm like, I think my people are coming to me more informed right now too, you know?
yeah, we definitely have.
It's awesome.
So
I
it's
always
great.
like to ask people if there's one bit of advice you got that you think about, or a phrase or a saying that you love, something in your family. Is there anything that comes to mind? Could be a cliche or a non-cliche.
And I think the biggest piece of advice that um, that my mother has given often is really two pieces, right? The power of positive thinking, right? And also focusing on what we can control and really working to modify what we can control.
Which is literally the name of the
Yeah.
infertility game,
Yep. Yeah.
right? Dr. Douglas,
Yeah.
thank you so much for being here. We will, of
Yes. Thank you
course,
so
link
much.
out to Extend Fertility and to all your info, but it was so fun to talk to you, and I appreciate the insight on the immunology piece too. My audience is really going to appreciate that.
It was great to be here. Thanks, Abby.